Good day to everybody. I think we can start. My name is Astema Kasimova. I'm the General Secretary of the Chamber of Commerce in Kazakhstan. Welcome to the Chamber's webinar. Today's webinar will be devoted to just one topic, but very relevant today. COVID-19 epidemic in Kazakhstan and France. And for this webinar, we invite the speaker, whose name is Asel Musabekova. She's a molecular biologist and virologist. She will present herself in detail later. And the webinar will last 1 hour, presentation, about 30 minutes, and discussion session. So the most important part of this webinar is the discussion. Before starting the webinar, let me remind you some of the Zoom rules. First of all, please keep your microphones turned off during the whole session. If during the presentation we'll have any questions, please write them in the chat. And during the session, the speaker will monitor your questions and will try to answer them. Or you can ask your question during the discussion session.
Right.
And yes, we wish you all a fruitful webinar. And before starting, I will just wanted to give the floor to the General Director of the Chamber, Munira Abdukaimovna. Munira Abdukaimovna.
Добрый день, я хочу поприветствовать всех участников сегодняшнего вебинара. Tout d'abord, je voudrais saluer tous les participants de notre réunion d'aujourd'hui. Нам всем известно, что в Казахстане сегодня санитарная ситуация непростая, поэтому думаю, что сегодняшняя тема, она будет всем полезна и интересна. Nous savons bien qu'aujourd'hui, la situation sanitaire au Kazakhstan n'est pas facile. Et je pense que le thème de la réunion d'aujourd'hui sera utile et intéressant pour tout le monde. Вы можете задавать свои вопросы писать в чате. Et желаю всем хорошего вебинара. Vous pouvez poser vos questions, vous pouvez les écrire sur le chat ici. Et je voudrais remercier aussi notre speaker, Asel Musabekova, qui parle avec nous aujourd'hui de la France. Я хочу поблагодарить нашего спикера Асель Мусабекову, которая будет с нами сегодня вести это собрание из Франции. Bon réunion и хорошего собрания. Удачи всем.
Спасибо большое. Thank you very much for inviting me. I'm very happy to be here with you today. So basically, the presentation will be in English. Скажите, пожалуйста, может быть, кто-нибудь, если нужно, то есть я могу переводить на русский язык. Также вы можете на русском языке задавать вопросы в чат, или вы можете задать вопросы потом уже во время дискуссии, но сама презентация будет идти на английском языке. Вот, возможно, кто-то из вас как бы предпочитает коммуникацию на русском без проблем, то есть я могу остановиться, и если что-то будет непонятно, вы пишите, пожалуйста, в чат, я буду прям по ходу переводить. Vous pouvez aussi poser vos questions en français, il n'y a pas de souci, donc vous pouvez aussi écrire en français si vous voulez vos questions. Sinon, on peut discuter après la présentation, donc il n'y a pas de souci. Je peux traduire tout de suite si quelque chose n'est pas clair. Okay, so now I will move to English. And basically today the topic is how we tackle COVID-19 pandemic in France and in Kazakhstan. If you have any questions, don't hesitate. We're also going to have, I hope we're going to have active discussion after the presentation. So I'm basically here today as a scientist, but also as a citizen. And I think more as a citizen than a scientist. And I will just briefly introduce myself. So basically, so my name is Asiel Musabekova. I have graduated from the University of York with bachelor in genetics. Then I moved, I studied in Eurasian National University. It was biotechnology for my master's. Very important course that I took, intensive 1 month course in vaccinology from Institut Pasteur, and this was my first encounter with France. And then basically I worked in Nazarbayev University for several years to establish the first biology labs. And we were the team which established the first biology teaching and research labs at Nazarbayev University, which I'm very proud of. And after that, I moved on to my PhD, and I graduated last year with a PhD in molecular biology from the University of Strasbourg. Now, at the moment, I am in Chambéry, in Savoie. So that's why you see mountains on this picture, because this picture for me, it's from my balcony. So it's really a symbol of the confinement for me. Basically, my fields of expertise are molecular biology, virology, immunology, vaccines, everything what comes to infections. I am not an MD, so this is a question that I get a lot, because so I have no right to give you any medical recommendations. But what I want to do today is to have a scientist view and a citizen view on what are the differences in tackling epidemics in these two countries. So also I would like to say about my volunteering activities during this epidemic. Basically, I started my blog recently on Instagram because I feel the need that we need to translate science into normal language for Kazakhstani citizens. Why? Because actually it started from the vaccination discussion. As you know, we had a lot of discussion in the society, and there was a lot of fake news and conspirology regarding to the medical questions, especially the question of vaccination. And then it moved also to the epidemics of COVID, because there are also many problems in understanding how science works. So basically, this is my little volunteering activity. Also, there is a huge team of more than 100 scientists and doctors, which are called MedSupport KZ. And this is an initiative which translates evidence-based resources about COVID-19 for doctors in Kazakhstan. So basically, we translate scientific articles from English to Kazakh and Russian, and we make really available resources for our doctors and for the general public. My aim in my volunteering activities in science communication is to create a network of professionals in science and medicine to produce evidence-based informed decision-making, basically what we lack in our country and in many parts of the world is when scientists actually can say policymakers what to do in this kind of epidemics. So unfortunately, the bias is towards the political policy making and decision making. And in many parts of the world, there's not too much of the scientific discussion. Do you have any ties with Young Researchers Alliance in Nazarbayev University? I don't at the moment. I do follow them, but I am not in the Young Researchers Alliance. So thank you for the question. Now we move to the topic, right? And basically, when you look at this map, you can see that it's a small world. It's basically a map of airports, which are connected by more than 60,000 routes. This map, you can see the boundaries of all of the continents, because we can be in a few days in any part of the world. Not at the moment, because at the moment we cannot really fly too much, but normally outside of epidemics, we can reach any part of the world in a matter of days or even hours. And the same happens with the infections. That's why we're so vulnerable at the moment, because any kind of infection which is found on any isolated islands can be with us in our kitchen in a matter of 2-3 days. So that's why the epidemics, tackling epidemics, communication during the epidemics is something that we all have to learn. And I would like that everybody has a basis of scientific thinking so that we can learn and we can make decisions based on science. Now, speaking about managing epidemics, we have to speak about this number, which is R0 or R0. It's the basic reproduction number, which depends on the contact rate, on transmission probability, and on the length of the infectious period. So basically, it depends on the infection, on the virus or the bacteria which we want to fight. And in this case, so every factor that affects the reproduction number, we can have a measure which respond to this factor. For example, the contact rate, of course, we will introduce, for example, quarantine to reduce the contact rate. Transmission probability, we could wear mask, or we could use a social distancing to reduce this transmission. The length of the infectious period we don't have as much effect on, and it's quite long for the COVID-19, so it's more than, so for example, if you take influenza virus, it's like a matter of 2-4 days when the patient is infectious. And with the case of COVID, it's up to 14 days, up to 2 weeks. And this makes it very difficult to tackle because it's quite long. Now, for the controlling R0, we have two kinds of strategies, the mitigation or the suppression strategies. And if you compare the countries, you can compare, for example, Sweden and France, where in France, you have had the strict quarantine, and in Sweden, not so much. What is better? We still have to judge. We still have some time to analyze after. However, most of the countries, they have taken the suppression strategies. Now the RT, the second number, is the effective reproduction number. It changes with the time of epidemics because the part of the population becomes immune, or if we have a vaccine, it will be vaccinated. So this is the basic of basically epidemiology for the managing of epidemics. Now, when we manage the epidemics, basically there are factors of the system which affect a lot, and that's why we have seen the differences in between the countries. If you take Italy and Germany, for example, how it was tackled in Europe. And basically what doesn't change is the nature of the infectious agents, because the infectious agent, the virus, SARS-CoV-2, which we have here in this epidemic, it doesn't really change as much. And basically this is our common enemy. Everything else, the preparedness of the healthcare system, implementation of the control measures, the compliance with the control measures, and this includes a lot of cultural differences, as well as social welfare in the country, they change depending on the country. And this is something, so basically this is the main topics of the discussion today. But first, in order to introduce this epidemics to you, I would like to speak about the virus itself, because this is something that is constant worldwide. The virus that causes COVID disease is called SARS-CoV-2. And here it's a, I'm sorry, it's quite complicated, probably picture. It's not very easy to understand. However, just for you, important to know that this is an RNA virus, meaning that the viral genome is the RNA, which is basically packed into the package of proteins and lipids. In this case, this is the enveloped virus. It means that it has a lipoprotein shell. And why is it called coronavirus? We all know, because of the spike proteins on the surface of the protein. So, and they form a crown similar to a crown of the sun. Now, the spike protein, it has an ability to bind onto, to bind onto the receptor on the surface of the human cell, and this receptor is called ACE2. This receptor is present on many kinds of cells, especially the endothelia of our blood vessels, and about which I will speak a little bit later. So basically, you remember of the SARS epidemics, which was 17 years ago. It was in 2003, 2004, and there we had the first SARS-CoV, the first version, right? And now we have the updated version basically of this virus. And what is the point of this update? It's more than 1,000 times more effective to bind to this ACE2 receptor. So it's basically a very, very efficient binder and very efficient virus to infect human cells, because it has this structural change comparing to the previous version. And the virus enters into the cell. So, and then it uses cell system, for example, cell ribosomes, in order to replicate, to multiply itself. So first of all, the viral RNA replicates, multiplies, and then we have the translation of viral proteins. So basically, the virus is produced its parts, and these little parts are then assembled into the viral particles, which are released from the cell. So this is the life cycle of the virus. Now, in the importance of the communication during the epidemics is so it's very essential to communicate it in a right way, because the problem is that we get the information about the infectious agents as we go. So the epidemic started in the beginning of 2020. We got the first genome the 21st January 2020, and then from January on, many scientists, like thousands of laboratories, they studied this virus a lot. And now we're quite lucky in Kazakhstan that we got into these epidemics late enough, because we already know quite a lot about this virus. So one important thing to remember about this virus is that it's not typical respiratory virus. And so, as I said already, excuse me, could you please kindly switch off the microphone? That'd be very nice. Вы не могли бы, пожалуйста, выключить микрофон, потому что звук чуть-чуть мешает. Спасибо большое. Okay, so as I said already, this updated version of the virus is 1,000 times more effective in terms of infectivity. The important thing that it's because of this high infectivity and high ability to bind, it can infect several cell types and tissues. And as a result, what do we get? We get different symptoms depending on the current health state. Basically, we have people at risk. These are the people with diabetes, sickle cell anemia, with obesity of different states, autoimmune disorders. We have people with kidney problems. So these are the people at risk. Why? Because actually they already have problems in the cells which can be infected by the virus. And then there are people of a generally good state. And in these people, the virus behaves completely differently. Basically, the 80% of people, they will be like so they are basically in good health in general. And most of these people will not have too much problems. So in 80% of people, you're gonna recover just by probably taking paracetamol and lots of water and by resting in 10-14 days. So this is the majority, and this is really something that we have to remember, because it really decreases the panic and anxiety in the society. Because if we remember that most of the people actually recover quite well, it's just that the period when we get the symptoms, it's quite long. That's why it's not too easy to get over it. And then we have the 20%. And then in this 20%, two major complications. These are the cytokine storm and also the problems with thrombus formation or different kinds of coagulopathies. But the problem is that this virus is quite clever in a way that we don't have a universal treatment for all these people. So basically, the behavior of the virus will depend on current health state of the patients. And for example, with coagulation, the virus can lead to two opposite effects. So in one way, it can lead to microthrombosis, disseminated microthrombosis, which is quite sudden. And on the other hand, it can lead to bleedings. And basically, these are the two extremes of this balance of coagulation. So this is quite a complicated system. Now, based on this information that we know about the virus, so the virus is something that is common for the whole planet, and it behaves commonly because this is a biological entity and we know something about it. So in theory, when we imagine the COVID epidemic, especially the peak of the COVID epidemic, we have, first of all, implemented the social distancing or quarantine. People are wearing masks. We have decreasing number of infected people. So we give the medical system a chance to adapt and to recover. Then we have 80% of people which have mild disease, and then these people will basically, what we have to do is we have to let the immune system work. And the main thing that can help the doctors in this case is when the patients will have the diary of symptoms. And I speak about this a lot because this is, it seems quite easy to do and it seems quite straightforward, but most of the people don't do it. They don't keep the symptoms actually. So basically what you have to know the symptoms, and then normally in 80% of the people you have the recovery in about 2 weeks. And by this, by letting your immune system work and by noting your health state, you're reducing the additional load on the healthcare system. And however, we have this 20% of patients where you have the possibility of severe disease. And here, when you have this diary of symptoms and you note them every day or even a few times a day, if you notice a progressing worsening of the symptoms, and then you have already the severe state symptoms such as, shortness of breath, for example, and the temperature which cannot be tackled with common drugs such as paracetamol, you are a subject for hospitalization. And then when you are hospitalized, now worldwide, we are starting to implement the efficient prognosis systems. So for example, as I said, two major complications are the cytokine storm and coagulation problems. So for this, we have two main prognosis factors. So interleukin-6 measurement for the cytokine storm and D-dimers measurement for coagulation problems. So these are the measures, the factors that are taken now in the laboratories worldwide for the hospitalized patients. And like that, we can prognose their state, the severity of the state. And based on this and on the other analysis, we can have informed evidence-based decision about the necessary interventions, about the therapy, because the therapy will change a lot. So we cannot have one universal therapy for all severe patients with COVID. This is, I see that this is happening now in Kazakhstan. It happened as well in France, because before we didn't know as much information about the virus. But I am as a scientist, so I know that it's difficult in practice. However, we have to try to have informed decision about every patient. So this is like in an ideal case. So this is how the peak of COVID epidemic could look in theory. Next slide, just a second. This is how the COVID epidemics in Kazakhstan happening now, unfortunately, and this is basically this is my view as a scientist and as a citizen from outside. However, I think many will agree with me, and I would like to discuss with you your opinion on this picture. So first of all, in Kazakhstan, we have this problem of low level of compliance with distancing measures. So we have very low number of people wearing masks. We have so-called super spreading events, for example, weddings or funerals, or people queuing outside the pharmacy where you don't have the social distancing, you don't have the ability even to keep the social distancing. And therefore we have the increasing number of the infected people, which overloads the system. Now you have still the infectious agents is the same, the virus is the same. So basically 80% of people will still have the mild disease. However, the healthcare system and also the anxiety and the panic in the society, which is caused by all this crisis, it actually pushes people to misuse the medications. So first of all, part of them will still recover in 2 weeks without a problem because they will just let their immune system work. But many of them, unfortunately, they will purchase serious medications without prescriptions, or they will buy them with prescriptions but with no apparent reason. So the doctors as well, they unfortunately, they practice the misuse of prescriptions. They have a dangerous misuse of medications such as dexamethasone, prednisolone, anticoagulants when they don't need it. And this actually pushes them to the unnecessary hospitalization. So basically we skew this percentage 80 of 20 and we increase the number of the possibility of the severe disease. So this increases the number of complications, and this makes the efficient prognosis and individual approach in the reanimation in the intensive care unit improbable. So it's impossible now at the situation which we have in Kazakhstan at the moment to implement efficient prognosis and individual approach due to several reasons. Of course, we have the system unpreparedness, those systemic measures which were not taken, but also we have this serious misuse of medications, and many of the cases of the patients which get into the intensive care units, they actually get there not because of the virus, but because of the mistreatment that they took before when they didn't need it. And in the consequence, first of all, it increases, of course, the death rate and serious complications, as we can see from all kinds of social media, all of these sad messages that we receive in our families. And then we have the long-term consequences, for example, antibiotic resistance, of which I will speak later. And as a result, we have a collapse of the healthcare system. So this situation, it looks quite pessimistic, and I think that we have to have informed decisions to do something with this. So every problem is easier understood in the comparison, and here we come to the comparison of France and Kazakhstan. And I think I have some right because I have lived in France for 6 years. I'm living here now. I have witnessed how the quarantine was here and how the peak of the epidemic happened here in France. So that's why I would like to compare briefly the statistics, the data quality, the data reporting in France and Kazakhstan, the control measures that were taken and the compliance with the control measures of the population. Then briefly about the misuse of medication, cultural differences, and also I would like to mention the social welfare, because as we know, the COVID collapse is not only the medical crisis, but it's also a major economic problem. So now, when we speak about the statistics so far, in France, we have one major website. It's gouvernement.fr and info coronavirus. And in fact, we have, so this website, it gives all of the official information. I quite like this website. I like the representation that we have. And I liked very much the videos of former Prime Minister Edouard Philippe about the situation, because it was for me very interactive and very informative. So what we can see on this website in terms of statistics, we have so 177,000 more than cases which are confirmed, and by confirmed we mean here that these are the cases which were positively tested for COVID, and then quite a high mortality, and about 17%, so 30,000 of those have died, unfortunately. And I think one of them here, one of the peculiarities of the French system comparing to Kazakhstan is that the 1/3 of deaths has occurred, unfortunately, in the nursing homes. And here you can see, so it's separated from the death in the hospital. Then important numbers is we can see now the people in the intensive care units and newly hospitalized patients. We also see here in the map, this is a map of hospitalization. So this is a map that really tells us about the situation at the moment, which is quite nice as well. And basically you get all of this information as a graph, and we can see that the peak is passed and the graph is steadily going, you know, straight. Just a second, I will read. What do you think about integration of coronavirus cases with pneumonia? Yes, that's a very good question. And how is the situation in France? So in France, basically, so the question is about whether do we count the numbers of pneumonia which are negative for COVID or which were not tested for COVID in these statistics. So basically in France, the statistics works like this. So these are the confirmed cases. So these are the cases with positive COVID. So PCR for COVID was positive. And separately, I know that there is a major program with testing for antibodies. So to get the information of how many people were immune, and these cases will be added, but I don't think it's done massively at the moment. For the testing, actually, in the beginning in France, when we had this possibility, all of the contact people were tested. So for example, we have a positive case with a shortness of breath, a person is hospitalized, and all of the contacts are tested. Then when we had the peak of the epidemics, of course, there was no time and no resources to test everybody. So I think, of course, at the moment, in all of the countries, we have this problem because we cannot test everybody. And this is a lot of resources, this is a lot of time, and also the problem with the test that we get a lot of false negative results. This is a human problem in terms of human resources, because the PCR has its peculiarities as a test. But however, in France, so basically in short, yes, it's only positively tested. So all of the confirmed cases. In Kazakhstan, I know, so in Kazakhstan, when we look at the statistics in Kazakhstan, so here in France, you remember we had about 17% of mortality as to the positively tested. Here we have 75,000 in our country, 75,000 of positively tested, so confirmed cases. And we have about 600 of deaths, which is very low comparing to France, but we have a lot of questions of whether this data is actually valid at all. Because, well, I think by the naked eye, when you look at the social media reports, when you look at the independent reports of data collection, we see that the mortality is much, much bigger. And also that the number of the positive cases is also much, much bigger. I know that from the 1st of August, the government decided to count the pneumonia cases. I encourage the Ministry of Health actually to have, to really have clear procedure for this counting, because it creates a lot of confusion for the health workers. It creates a lot of confusion for the social welfare, because we have certain social programs which, so you have certain payments which are made to the positively tested people, and especially positively tested health professionals. And I just encourage to have this procedure as clear as possible and explain it as clear as possible, because not all of the cases of pneumonia can be added. There is a certain clinical outcomes of the viral COVID pneumonia, and we have to have a certain clear procedure of the rating of how we rate the pneumonia that we see. Also, probably it's a good idea to count indirect causes. So COVID as indirect cause of death because of the collapse of the medical system, because many urgent patients, for example, with cardiac failures and things like that, they cannot be accepted into the units because of the COVID crisis. So we had, as I recall, the question would be also, are those two sicknesses linked, or are they coming from two different viruses? Yeah, this is, I think I explained, because there are basically certain clinical implications of COVID pneumonia, but I think this is a question of the training of the health professionals to basically to teach them efficiently and quite in a fast manner to distinguish the two. As I recall, according to today's news, Minister of Health decided to dismiss all cases of pneumonia before 1st August in statistics. That's right, yes. So it's going to be happening from the 1st of August. But I think as soon as the procedure is known, because I think, as far as I know, the ministry, they contacted WHO to basically for an advice on how to formalize this procedure. Now, when we look at how the statistics is counted in Kazakhstan, I think we have to note several things. So, for example, for me as a citizen and as a scientist from outside, there are several points to note. So, there is no data on severe patients or on hospitalized people. And this is what we see in France, and this is what for me is very clear indication of the current situation today. So that would be great if we could have this information. Also, the data on the mortality, what we get, we don't get any graphic representation of the sex, of the age, of different complications or like chronic diseases. So we don't have the information about the population which get into the severe, in this 20%, and which unfortunately die. The only information that we get is case by case, where there is a written age and sex. However, I think that would be great if we could do some analysis with this data and to represent it in more a clear way, so that the people are aware what are leading causes, underlying causes of death with the COVID. Then there are many problems with PCR tests, as I mentioned already. So that's why that's why we get this counting problem, which we already discussed. And as I mentioned also, that'd be nice to have this indirect deaths caused by the system collapse. I have a few ideas how we could count it, but there are basically epidemiological procedures to compare the general mortality by period, right? And to see whether some mortality cases have increased in this period. We are counting by region. So you see this map here, and the cases are counted by region. And this is very good because we have a lot of regional differences in Kazakhstan. And this is a very good idea. However, measures that are taken in terms of quarantine, they are taken not really by region. So what I see in France we had this map, as you remember probably, that we had regions which were green, orange, and red, according to the situation. At the moment, I think all of the France, continental France, is green. And this was actually quite nice for me in terms of visualization when Edouard Philippe was speaking with the update of the situation, when we had these colors of the regions, and the measures were taken accordingly. So, for example, I have now I'm living in Savoie. I have lived in Alsace. So in Alsace, it was actually a major crisis, and especially in Mulhouse, and there they were stricter measures than in Savoie, for example. And this is quite nice because you don't get as much of response of the population, a negative response to the confinement measures, because they're actually treated quite differently region by region. And that, I think, something that we could implement as well, because we have already the data by region. That'd be quite nice. So when we look at the data in Kazakhstan, the situation by the official data looks much better than in France at the peak of the epidemic. However, we see with the naked eye that the situation is much worse. So what is the decision for this? We have an urgent need of independent data acquisition. So for example, there is a site called Umutpa KZ, which means in Kazakh, don't forget. And this site, this website, actually it gathers the cases of deaths because of the coronavirus, and this is one of the independent sources. Several initiatives have been started already to tackle this problem, and I think there is no, we don't have to feel ashamed because we have some independent data acquisition. This is a normal practice in epidemics. epidemics is something urgent, and I understand that the government is a bit late with the statistics, and that there are many problems with the statistics. It's completely normal. And I think that the Ministry of Health should accept this independent data acquisition as a must here, because this is the basis for our future work of how to manage the epidemics better. And we have to really accept the fact that we need these independent sources of data. I spoke with epidemiologist and who is a professional in this field. I have a separate big interview with her on one of the websites I will show you later. So she said basically that even if there are mistakes and differences in data acquisitions from different sources, we can still account for them when we do the analysis later. So the important part now is to collect all the data possible from all the sources possible. We have one question, sorry, I have to leave them. Okay, that's no problem. Now let's move to the control measures. So we talked about the data quality. The control measures in France, as you all probably know, the quarantine was quite strict. It started from the 17th of March, and the strict measures were held until the 11th of May. From the 11th of May, we had very slow and very progressive déconfinement. So the exit from the quarantine. And now, like latest news from last week, we have masks obligatory in closed public spaces. And also what I noticed here, so basically everybody was waiting. I remember when we were during quarantine, everybody was waiting for this date, 11th of May, that finally we're going to be free and we can walk as much as we want and go where we want. However, from 11th of May, we had a little bit of disappointment because the déconfinement was very slow and very progressive, but I think it was a good choice as a strategy. First of all, in epidemiological point of view, because when we have a sudden release of strict measures, of course, we will have a sudden rise on the infections, because this is what happened in Kazakhstan. And also the second very important aspect of this very slow deconfinement procedure is a psychological effect, because psychologically, especially for the French citizens which have liberty in their blood, it was very difficult to comply to the strict measures. And I think it was a good idea to have this very slow procedure of releasing the measures, because psychologically we were not prepared to have sudden changes. And a question, I have heard that immune system does not work with the COVID. It could come back. Yeah. Okay, for the immune system and for the antibodies, it's a very good question. Thank you very much. I will, we can talk about this later after the presentation. So how the control measures differed in Kazakhstan. So we had some period of strict quarantine. The cancellation of quarantine was for me, from my point of view as a citizen, quite sudden, and due to the cultural differences, we had a rise of super spreading events. What is the super spreading events? These are the events where you have a lot of people gathered together, for example, weddings or funerals, or other kinds of family events. And unfortunately, we had low compliance with the rules. Now, some of them, from my interview with epidemiologists, she shares some preliminary data from social and behavioral studies, and actually they show that this low compliance with the measures, it comes actually from the low level of trust, low level of social security. And this is really about economical and social problems. Now let's compare how it was tackled in the two countries. So when we speak about the social welfare in France, I am a person who lives in France, who is not a citizen of, who is not a French citizen, but I am nevertheless supported by the social welfare in France because I work here and I pay taxes. And generally in France, as we know, the social support system is very good. So we have CAF, allocation familiale, we have Pôle emploi, which helps the unemployed. And here we have the Fonds de Solidarité, meaning that these are the special funds which were made during the COVID pandemics. And you have already 5 billion euros which were paid to about 4 million of the citizens, right? And you can see by the map here which regions were most affected by these funds. And so there is this solidarity funds for the COVID. There were also specific aid programs for during this COVID crisis, for example, to the artisans, to the farmers. So really certain parts of the society which were the most affected, the government have started a certain programs to fund them, to help them. Because this social welfare, it basically gives the people it gives the support that they need to comply to the measures that the government is taking. Now in Kazakhstan, we have also this program which pays 42,000 tenge to the people in need. I think it was done twice for some cases, so for 2 months. Officially, more than 4 million people received this aid, and this accounts up to 300 billion tenge. However, for me, well, I think this is the obvious reason, difference, that the procedure was complicated. Unfortunately, the procedure of applying to take this social aid was produced many super spreading events. So basically at the peak, during the quarantine, people were actually crowding in order to get this social aid and in order to apply for this. So this is something that probably I think is not acceptable during the epidemic. So we really should have clever decisions of how we can socially, we can help our population without causing the super spreading of infection. I can see that there is, how did unemployment rate change in France after quarantine? What is your opinion? I think there was a mild increase. I have no, I don't have the numbers at the moment. I can just say that the Pôle emploi, it had a specific program for the people who could not work because they had kids at home. So basically you could have the right of go on the chômage partiel, so partial unemployment, where you could keep your contract and still be paid by unemployment social help and not by your employer, which is also quite nice for the employers because the employee doesn't work. So it's very difficult for the employers to get to be profitable. And in this case, the government supported a big number of these people by partial unemployment program, which is while at the same time letting these people to keep their workplace, which is, I think, very nice idea. For the numbers, I don't have the exact numbers at the moment. Now, I would like to also say, so so now we understand that this compliance with the strict measures, with the quarantine, with the social distancing, it's really affected by the state in which the people are. So basically, when we have the trust, when we trust our government, when we believe that the government will protect us socially, we will comply to these measures in a better way. Here in France, additionally, I have found the big difference in the way how social distancing was supported by the government, by not like by quite small measures, but they were quite effective. For example, the masks were made available by employers. So my husband, he works in the laboratory, for example, and he has to wear a mask all day, but 3 masks are available fresh and new every morning for him by his employer. Also, we received the mask from the local authorities, and we received 2 sets actually, 1 set from Chambéry and 1 set from Strasbourg. So this really shows the care of the local authorities, of the mairie to the citizens. Then in the public transport, there were several programs to exclude the crowding in the public transport. So one program specifically that I like, for example, all of the citizens, they have the right of 50 euros to repair their bike. And this is very nice in a way that you promote the healthy lifestyle, so using the bike. You give this money to the small companies who do this bike repair. So you protect also the small businesses. You also decrease the crowding in the public transport. So this is a major cause of this program. And also these small programs, they make the people feel important and feel heard. So, for example, our family, we used this measure. We went to the bike shop. We had our 50 euros, and we repaired the bike, which was in the basement for a long time. Also, like things like sanitizers are available, and the disinfection measures were reinforced. Basically, I feel that if the population sees that the government makes some effort to actually organize the social distancing and masks in a way that it will promote and it will explain, and the population will have the information why it is important, I feel that the compliance with the rules will be much, much better. Now, another big question, and this is a global problem, is the infodemic. It's the rise of the conspiracy theories and the fake news. And why is it a global problem? We can see this trend everywhere. So we can see how the President Trump speaks in the public of injecting sanitizer into the blood and things like this. So we can see all of this chloroquine story. In France, of course, it was a big story, and it still is a big story with Professor Didier Raoul, who is defending the chloroquine treatment. And of course, this is something that we all have effect on, because the social media is so strong at the moment, and because we have not a lot of official information, because this ongoing epidemic and the virus that we don't really know, it gives rise to many kinds of conspiracy theories and the fake news. What is the difference in this infodemia in France and in Kazakhstan? In Kazakhstan, unfortunately, this infodemic leads to more serious consequences. I will explain why. Just a second, I will just see, no questions, okay. So in Kazakhstan, the fake news and the conspiracies became a trend. So major celebrities, which have like millions of followers, they are spreading this fake news. They are spreading the dangerous conspiracies, for example, that chemtrails from the airplanes, they disperse the virus and things like this. So why is it more dangerous in Kazakhstan? Because in Kazakhstan, we have access to serious medications from the pharmacies without prescription, or with the prescription that is not needed. I will explain you with one example. You all probably heard of this drug, which is called dexamethasone. And it all came from the news, actually from a respected news source. It's a BBC News, right? And it was in the middle of June. The dexamethasone was called a breakthrough by BBC. These news were suddenly translated to all languages. It spread quite fast, because dexamethasone is something that is available, that is cheap. And in France, basically it's used only in the hospital setting. In Kazakhstan, unfortunately, the same day the news were translated and the medication was available without prescription. So people started to buy dexamethasone. How should it be used in a normal setting? It's only useful in the low doses in the patients that require oxygen, so the patients with a severe disease. It's completely prohibited for use in patients with a mild disease, because it can disturb the immune response in the first phase of the disease, and because it can also cause side effects. Now, the consequences of dexamethasone misuse in Kazakhstan are uncontrolled purchase. So we have the shortage of stock of this medication, and major side effects from this medication and from the homemade injections of dexamethasone. There are increased cases of the severe disease, hospitalization because of the kidney failure after the dexamethasone and heart failure after the dexamethasone take. And sorry for this picture, but this is an example of what we see in the patients which misuse the treatment at home, which have a lot of, so there are a lot of problems and a lot of hospitalizations because of the homemade injections. I can see that I actually overrun the time. Is that okay? Should I continue, or should we actually sum up and go into discussion, Asim? Because I didn't expect that it would take so long. Asim, do you hear me?
Yes, sorry, I didn't turn on my microphone. Yes, you can continue your presentation.
Okay. So it will finish quite soon. I will just wrap up. I will try to make it faster. So basically, also, what is the problem with this misuse of medications? There are long-term consequences which are quite important. For example, antibiotic resistance. We all know that antibiotic resistance is a major problem in Kazakhstan. Kazakhstan is a champion in multi-drug resistant tuberculosis. This summer, everybody uses antibiotics which are not prescribed or which are prescribed, but some serious antibiotics which they don't need. The studies show that in COVID patients, antibiotics were used in 70% of cases worldwide, whereas they were needed in only 10%. But antibiotic resistance in Kazakhstan is really a huge problem, and I think it's a crisis which is even bigger than the coronavirus itself. So the next flu season, we're going to have a lot of deaths because antibiotics don't work. And this is something that our government should pay a lot of attention to. And this is just a map showing that our region is really affected by the antimicrobial resistance. And also we have a lot of medications or a lot of use of things without any clinical evidence. And this is becoming dangerous as well. This infodemia, it leads to a lot of consequences which are not related to the virus, but are related to the misuse of things that are not used in the rest of the world. Now, one last important point is the health workforce. Basically, health workforce is the state of the medical staff during the pandemic, which we need to control separately because we depend on these people. In France, there are organizations which actually defend the rights of the health workers during the epidemics, and they have their independent counting of how many of the doctors have died and nurses have died during the epidemics. And this is very important because otherwise we get all of the doctors which would die and we would have no doctors to treat our patients. In Kazakhstan, we have extreme shortage of personal protective equipment. And this is something which shows the unpreparedness for the peak of the epidemics. We had this time to prepare, but we didn't prepare. And now we have a big shortage of good quality personal protective equipment. And also, we had this waste of healthcare workers on asymptomatic patients since March. So since the beginning of the epidemics, we got asymptomatic patients into the clinics, and healthcare workers, the nurses and the doctors, basically the human resources, were wasted on the patients which didn't need the medical help. And this brings us to the cultural differences. Because in Kazakhstan, we have low compliance with the rules, and this traditional lifestyle, unfortunately, it affects a lot the situation. In France, I think for the population, it was a big shock and a major behavioral change. I have heard the people saying that since the World War II is the biggest crisis, and many people needed psychological support. In Kazakhstan, I think people are probably less vulnerable to the changes like this because these are the people who survived the 90s. However, the mentality is one of the key problems because the socio-economic status of the people is important. And I think here we have to really make some behavioral studies to study this question in more detail. So in conclusion, I would like to say that we have the urgent need for elegant, clever decisions. For the short term, we have to have full data about the epidemics, and the data acquisition should be from different independent sources. We have to take measures to limit the medication misuse and associated complications, and we have to support independent initiative, for example, MedSupport KZ that I'm working in as a volunteer, which help to stop the infodemy and to spread the knowledge. And in the long term, I feel that the voice of the scientific community must be heard in our country. So we don't have really communications between scientists and doctors and the government. Scientists have no share to say about this epidemic, unfortunately, although we all need good scientific information explained clearly to all population. Then we have to have, so because of this, we have to have new efficient communication strategies based on evidence, based on scientific and medical evidence. And in a big scale, we have to make a lot of behavioral studies to understand our own population in order to respond to the epidemics in more efficient way. Thank you very much. I'm sorry that it took me so long. And now we can move to the questions. So there was a question from Monsieur Lenoaik that about the immune system, that it doesn't work with COVID-19. So basically the question is that we have our immune system, which have several branches. So we have the B cells, which produce antibodies. We have the T cell immunity, where we have special T cells which are trained to kill virus-infected cells. And studies recently have shown that we have the combination of two which work against the COVID. This actually brings us to the question about vaccines, because we have no idea at the moment whether vaccines will work. Of course, we have some vaccines, especially the Oxford vaccine from AstraZeneca, which works better than others because they succeeded to make the conclusion that it was safe. However, I, as a vaccinologist, as immunologist, I have to urge you that we have very little information about how it will protect from the virus, especially because we don't exactly know how the immune system works against this virus. And we don't know exactly whether the antibodies that are produced, they will help, they will stay for a long time, first of all. Also, there is an event called antibody-dependent enhancement. And this is basically a mechanism which the virus uses to help itself. Basically, the virus can even use the antibodies from the vaccine to proliferate more. So the conclusion is that the vaccine can not only help, so not only can probably it not, but like it cannot be protective in some cases, but also it can help the virus. So we have to be really careful now at the moment when we make any conclusions about the immune system, about the use of antibodies as a therapy, and about the efficacy of the vaccines, because the virus which we have here is quite a complicated and clever virus. As an indirect implication of this, we don't have still the vaccine against SARS, which we had 17 years ago. So during the 17 years, we have not moved with the vaccine against SARS. And there are reasons for this. There are biological reasons, the complexity of this pathogen. That's why we should have hopes for vaccine, of course. However, we should really verify the efficacy and the safety much more than we do it now. Because now, unfortunately, the vaccine race, it became a political race and not a scientific race. And I would like, my dream would be that the scientists have more effect on the political decisions. That'd be very nice. Thank you for the question. It was very nice. Do you have any other questions? Vous pouvez aussi poser des questions en français. Je vais essayer. Да, или на русском, ага.
I have a question. My name is Arman. I'm GM of Lactalis Kazakhstan company. I have a practical question. So we have some people coming back from hospital after, let's say, 10 days to 2 weeks treatment. And what I personally do is I still keep them for less than 10 days in the home, meaning that to provide more time for recovery. What is your recommendation in such cases? Because I have a feeling that some people, recovering fast, some people recovering fast. And what would be, let's say, ideal scenario, 7 days, 10 days, or 2 weeks?
Okay, so basically there are studies which show that after recovery, still during the 2 weeks, the person can be infective, but in some cases. In most of the cases, the official information that we get from WHO now is 2 weeks after the apparition of symptoms that the person is infected. So in terms of infectivity, I think there is not too much need after 2 or 3 weeks of the disease to keep the person isolated. In terms of the recovery, it really depends on the symptoms that the person gets. So basically, it really depends on the current health state of the person. If the person, for example, suffers from diabetes, we should really manage the recovery accordingly to this disease. Now we get a lot of people who get neurological complications. So even if the active phase of the disease is past, we get the neurological complications from the COVID, which we have to monitor very carefully, and the rehabilitation and the recovery will depend on the symptoms that this exact person takes. Because the problem with this virus is that it actively infects many kinds of cells. So mostly the important implication is, of course, endothelium of our blood vessels, because we have this receptor ACE2 on many kinds of different cells, or for example, kidney cells. If a person had underlying kidney condition and was infected with coronavirus, of course, it will take longer to recover for this person. So basically, the most important thing that the patient can help the system is by keeping the diary of symptoms and by really carefully noting everything what is outside of the normal condition. Because we are learning about this virus on the way as we go. And the complications, we get a lot of articles, scientific articles now about different complications. For example, loss of smell, it happens not in all the people. So it depends really on the peculiarities of the nervous system of this exact patients, of when the smell will come back. We have already reports where the smell didn't come back after 3 months of the disease. And this is something to note for the patient. And this is something that we really need to keep in mind.
Okay. Great. Asil, may I ask you?
Yes,
first of all, thank you very much for the great presentation. As you know, I'm a doctor, and I understood that all procedure is similar in Kazakhstan and in France. But of course, you said, можно я буду на русском?
Да, конечно, можно.
Я, конечно, увидел, что наше здравоохранение, оно не ориентировано на конкретных пациентов, оно приучило людей пить антибиотики и, в общем, много всякого неправильного. Но единственное, что я понимаю, что сегодня все стали себе докторами и все делают. И вот как все-таки во Франции, вот пока человек дома находится, ведь госпитализация, наверное, там тоже осуществляется, когда снижается сатурация кислорода или там появляется, неэффективно домашнее лечение. Все-таки в условиях дома что может получать пациент из лекарственных препаратов, скажем, кроме парацетамола там, и витаминов каких-то?
Кроме парацетамола и ибупрофена ничего.
Ничего.
Получается, что все, что касается гормональных препаратов, антикоагулянтов и так далее, даже аспирин тот же самый, это будет по рецепту врача. Дело в том, что рекомендация, даже попасть к врачу во время пика эпидемии было невозможно, пока нет одышки и низкая сатурация. Сатурацию, в принципе, даже дома человек не измерял. Значит, когда можно было звонить в скорую, реальное ухудшение состояния и плюс реальная одышка при там, походе в туалет и так далее, да, то есть реальные бытовые... А
пульсоксиметры давали домой? Я извиняюсь, пульсоксиметры
нет, пульсоксиметры домой не давали.
В Израиле дают,
То есть получается, что здесь есть разделение на людей, которые с большей вероятностью попадут вот в эти 80%, которые нормально перенесут, да, ну, молодые люди без осложнений каких-то, без хронических заболеваний. Есть люди, там, такие как диабетики, люди с ожирением, сердечными болезнями, у них была отдельная программа по мониторингу. То есть получается, что если человек...
Онлайн, да?
Ну, то есть, например, та же скорая, да, то есть у них, вот, насколько я понимаю, потому что я сама звонила в скорую в этот период, во время эпидемии, у них распределяется звонок в скорой, да, то есть если у вас вот такие-то underlying conditions, да, хронические болезни, то вы попадаете в другую линию, да, и с вами уже будет человек разговаривать отдельно, который уже знаком с осложнениями в этой группе.
Откуда они знают, что у вас есть сопутствующие заболевания?
Ну, то есть вы звоните, и у вас спрашивают, попадаете ли вы в группу риска. Здесь еще очень важно, что есть информированность населения, да, то есть группы риска, они реально были ясны, да, всем. То есть это было прям вот на слуху, это было даже вот в автобусах, да, есть объявление о том, что в группу риска попадают те-то, да, что они должны изолироваться больше, чем остальные, да. Это как бы говорит тоже о заботе вот этих вот слоев населения, да, которые, к сожалению, мы не показываем, да, вот мы своих старших родственников в Казахстане мы не изолируем, да, то есть мы не показываем вот эту заботу. Здесь это было прям вот большой был акцент, да, говорили, что внуков...
Государственной политикой, как бы, да?
Информированность, да, государственная политика по информированности и общая вообще информированность населения, да, об этом всем. Поэтому человек, когда он знает, что у него риск, он звонит, он будет попадать как бы в другую группу, в той же самой скорой помощи, и он получит, соответственно, другую помощь. Возможно, у них были, например, пульсоксиметры, да, вот. То есть, мне кажется, вот этот вот максимально индивидуальный подход, то, что мы видим сейчас в реанимации, я пытаюсь внедрить систему, ну, как бы, не внедрить, то есть я пытаюсь дать свое экспертное мнение как ученого о информации, которую мы имеем сейчас о прогнозировании, например, те же самые D-димеры, интерлейкин-6, да, которые, в принципе, в идеале они должны...
Кому вы даете рекомендации? Кому вы даете?
Есть инициативы, которые независимые от...
В какой стране, Аселечка? В какой стране?
В Казахстане, конечно, в Казахстане.
Вот я хочу следующим предложить вам такой диалог. Я, как бы являюсь членом общественного совета Минздрава, можем сделать с вами отдельный Zoom-диалог на час, и мы это можем отправить нашему правительству, министру, они смотрят. Но это отдельно между нами с вами разговор должен произойти. И последний мой вопрос. Вот я просто знаю, во многих странах человек должен был, прежде чем выйти в общество, на 14-й день сдать ПЦР, еще потом. Но вот вчера... и с израильскими врачами говорил, у них тоже отменили. Теперь, как у нас, 14 дней прошло от первых симптомов, все, можете выходить в люди. Потому что нагрузка большая на вот эти анализы. То есть не заразен уже человек, да?
Во-первых, ну, считается официально сейчас 14 дней, да, но я говорю, что были все-таки случаи, когда измеряли вирусную нагрузку в ротовой полости, и все-таки вирус еще оставался там в течение 3 месяцев.
А как можно измерить вирусную нагрузку?
Ну, то есть измеряют, да, ну, то есть ПЦР, да, измеряют ПЦР, и было показано, что вирус остается в некоторых случаях, но, в принципе, в этом случае даже человек, скорее всего, он не будет так же заразен, как он будет заразен во время болезни. Почему мы отказываемся сейчас от повсеместного тестирования? Во-первых, потому что это большая нагрузка на систему, у нас не хватает даже не то, что денег, а человеческих ресурсов, которые могут правильно это сделать, потому что очень много ошибок у нас в Казахстане из-за неправильного забора тестирования. Но и вообще, в принципе, по всему миру это глобально, это не только казахстанская, это глобальная проблема о качестве тестов. Потому что этот вирус, так как мы знаем, он любит именно нижние дыхательные пути, да, он очень быстро спускается в легкие, и мы можем даже его не видеть. То есть в зависимости от дня болезни, да, мы будем видеть совершенно разную вирусную нагрузку по ПЦР. Вот, поэтому как бы человечество отказывается от вот этого повсеместного, я тоже думаю, что это как бы оправдано. Потому что это и тревога, это false negative results, это, да, как мы все видим.
Спасибо. Очень интересно, на самом деле.
Thank you, Asel. I think we have a limited time, so last 2 questions. If other participants have any questions, please ask it now.
I have no question. I want to thank Asel. For me, your session was very good because it's informative, and it's a matter of great importance because I have some personal reasons. The point is, my daughter now in France for more than 1 year, and I didn't see her.
Yes,
Maybe
exactly.
1.5 years, definitely. I'm waiting when the border will be opening, but I know that she's safe and that she's okay. And thank you very much again for your session. Thank you. I wish you all the best.
Thank you very much for the feedback.
Спасибо. Асель, прошу вот этот линк между нами, чтобы сделать такую программу, ладно?
Да, хорошо, конечно, я буду очень рада.
Спасибо.
Thank you, Asel. Thank you, the participants. We will share the presentation on our website. We wish Asel good luck and good other research thank you for this very informative and useful information and very relevant for these days.
Thank you very much for the organizing.
Thank you. So we can...
Всем минуточку. Я тоже хотела поблагодарить Вячеслава Натановича за участие в нашем вебинаре. Мне было приятно вас видеть, слушать. И я очень рада, что у вас вот теперь профессиональные будут отношения с ОСЕЛЬ. Мы проводим такие вебинары, которые сейчас в такое время могли бы быть не только интересными, но полезными всем, не только членам палаты, всем нашим друзьям, знакомым. Поэтому вам, Асель и Вячеслав Натанович, удачи в ваших дальнейших встречах и собраниях. Можете иногда и нас подключать, будем рады. Спасибо всем участникам, удачи, успехов, берегите себя, своих близких. До встречи.
Спасибо большое.
Спасибо большое.